Thank you, Jason. Again, it's an honor to be here, and thanks for giving me this opportunity to talk about DOACs in atrial fibrillation. We'll talk about the practical update. Without further ado, these will be the objectives, learning objectives of my session. We'll talk about the risk stratification in atrial fibrillation. We'll talk about the DOACs versus warfarin in atrial fibrillation. We'll then recognize the appropriate use of DOACs across the various stages of CKD, and then other gray areas where we have elderly population, we have hepatic impairment, and obesity. So there's a lot to cover, but I'll try my best to go through these. So to start with, why we bothered about atrial fibrillation? As you can see, there is a huge burden of atrial fibrillation. You can see the global the prevalence of atrial fibrillation as well. There is 1 in time risk, 1 in 3 individuals at the lifetime risk of atrial fibrillation. It's more common in males. We know as the age goes, it goes higher as well, and in the elderly population, so it's high. So what can happen if you have an AF? You can have mortality, you can have stroke, you can have LV dysfunction, you can have cognitive decline with dementia, depression. So it's all affecting you. So it's atrial fibrillation is a disease spectrum. We're not talking about just one about stroke. We're talking about a lot of things. We have moved from CC to ABC in last couple of years, really. We used to do the confirm the atrial fibrillation by the ECG. We used to characterize the atrial fibrillation in terms of stroke risk, in terms of symptom severity, severity of atrial fibrillation, and then substrate severity. We're now moving to ABC pathway where we avoiding stroke by doing anticoagulation. We're having a better symptom control, and we are trying to address the comorbidities or risk factors. So when we talk about stroke risk stratification, on one hand, we have obviously the stroke risk. On the other hand, don't forget the bleeding risk. So, and we have to balance those. You're all very familiar. I'm not going to talk more in detail about the CHA2DS2-VASc score. So you're all familiar with this is one of the scores which is generally recognized as a good score. There has been some changes. I would suggest, especially the residents, to go through in detail about all these comments, that what changes have been made in the recent ESC 2020 guidelines about these risk factors. One thing to note is that this is the European Society, but the Canadians are also moving now to CHADS 65 score. You might have heard of CURB 65. Similarly, they are moving to CHADS 65 score, that if you are age above 65 with atrial fibrillation, if the answer is yes, you already should be on anticoagulation. And then you look at the risk factors if you are less than age 65. So on one hand, we talked about stroke risk stratification, but on the other hand, also bear in mind the bleeding risk. Again, there have been several bleeding risk scores. The most popular one is the Hasbled score. Again, in 2020 ESC guidelines, rather than just calculating these Hasbled score, we also talk about some non-modifiable risk factors, potentially modifiable risk factors, and the modifiable risk factors. So, for instance, in the non-modifiable, you can talk about age. You can't modify that. You can't modify malignancy. You can't modify somebody on dialysis. But things which you can modify is like well-controlled hypertension. You can decrease the alcohol intake. You can see that whether you need to stop their NSAIDs or stop their antiplatelets or not. You can have a better INR control, and you can have a correct dosing of DOACs. So this is how you actually not reverse, but decrease the bleeding risk. And as you can see, the more the Hasbled score would be, the more the bleeding risk would be. So again, I'll just let you go through this. So for instance, you have a patient with atrial fibrillation who is eligible for oral anticoagulation. Just keep in mind, if they are prosthetic mechanical heart valves and moderate to severe mitral stenosis, for sure they're going for warfarin with a good INR control, with a good TTR. TTR is the term which we use, time to therapeutic range. That should be good in these patients. But if you have a low risk patients, you then calculate their CHA2DS2-VASc scores. If they have no risk factors, so they're either males or females, but with low risk score, then there's no antithrombotic treatment. So it's not like you give them aspirin or clopidogrel. You are in atrial fibrillation, you don't need any DOAC, okay, if you don't have any risk factor. But if you have one risk factor, you consider that. And if you have two risk factors, so 2 with the male or 3 score with the female, you are going for OX. And now the DOACs or NOACs, what we call them, are generally recommended as first-line therapy for oral anticoagulation. So why not warfarin? So why warfarin gain, like almost now not being used for these population? Reason is this, the very tight therapeutic range, 2 to 3. As you can see from this graph, like if you go above, so taking the green, okay, for ischemic stroke risk, as soon as you go below 1.8 INR, your risk of stroke goes higher and higher. Similarly, your risk of hemorrhagic stroke or bleeding risk goes higher as you go above 3. And especially if you go above 4, look at that, the bleeding risk is going higher and higher. This is another very interesting article shown that if you have a good time to therapeutic range, like greater than 75% versus less than 60%, you can have a mortality difference as well. So look at the mortality of 4.2% per year and 1.69 if it's well controlled. Similarly, stroke risk of 2.1 versus 1. So warfarin is not bad. Warfarin is still viable. Warfarin just has to be very well controlled. The TTR has to be very well controlled above 75%. If it's not very well controlled, you're going to have more mortality, you're going to have more stroke risk, and that's why DOACs have become preferred over VKAs. So busy slide, all 4 trials which we know about. So we have dabigatran, we have rivaroxaban, apixaban, edoxaban, and all those randomized controlled trials. I know you can't go through them, but things which I'm just going to let you know that obviously dabigatran is the only one, the oral direct thrombin inhibitor. The rest of them are all factor Xa inhibitors. They all have time to peak hours, only 3 hours. The half-life is around 12 hours. They are renally excreted. So some of them, like 80% with Dabi, we have 33% with renal, we have 50% renal with edoxaban, and 27% with apixaban. So in terms of doses, I'll come to that here. These are the dose selection criteria. As you know that they have 150 milligram BID, 25 BID, and 60 milligram. And then there are some conditions where you go with a lower dose. So for instance, with apixaban, you have to meet at least 2 out of the 3 criteria. Similarly, we have rivaroxaban with creatinine clearance less than 50. You have to go for the lower dose, and similarly for others as well. So now let's talk about, so we kind of established that yes, warfarin is not bad, but warfarin has been preferred, so DOACs has been preferred over vitamin K antagonists for somebody who need anticoagulation. But now there are some people who have some renal insufficiency, they might have a hepatic impairment, they might have extremes of body weight, and let's take them one by one, because these are a bit of gray areas. So I'm going to talk now about DOACs and AF in renal impairment. They go hand in hand. We know that AF patients can have renal impairment. Actually, 1/3 of them do have CKD. The evidence says that if you have a CKD, you have a more risk of stroke or systemic embolism. You also have a more risk of major bleed. So both go hand in hand again. So what do we do? So this is the meta-analysis which is be done for patients who have a creatinine clearance less than 50. As you can see that in less than 50, it still favors DOAC, okay? And in terms of major bleeding, again, it favors DOAC. So DOACs are preferred for patients who have creatinine clearance of less than 50. How about when we go beyond less than 50? So we go for 15 to 30. So now this is very gray area, although there are trends in both stroke and systemic embolism and the major bleeding as well, definite trends towards safety, though the numbers are very small. The number of patients they are not randomized controlled trials. These are a subgroup taken from the randomized controlled trials, and there is no head-to-head comparisons among these DOACs. I quite like this slide. This is from Canadian Society. It essentially tells you that what to do with these AF patients with renal impairment. So you have a creatinine clearance greater than 50. You're all good. You can choose any of them and you can have these green doses. But once you go to 30 to 49, you might have to adjust the dose of dabigatran. You might have to adjust the dose of Riva and edoxaban, and consider lower dose if 2 out of 3 are met in apixaban, and so forth for creatinine clearance 15 to 29 and less than 15 as well. So again, beautiful diagram actually taking you through that if you have a normal renal function, you go for, or you can use any of them, except edoxaban has a black box warning, remember, above creatinine clearance of 95. If you have creatinine clearance of less than 30, you have other options as well. You avoid dabigatran. If you have creatinine clearance less than 15, you can, in some instances, use apixaban, but you kind of avoid others. If you have creatinine clearance less than 50, you have an option of Debi, rivaroxaban, and edoxaban. So how about elderly populations? We often think that the patients are elderly, we should not give them anticoagulation because they're high risk of falls, they're high risk of bleeds. Actually, on the contrary, there's strong recommendation, again, this is from Canadian Society, saying that there is moderate quality evidence that elderly patients are at high risk of stroke, so they should be, and they are more likely to benefit from anticoagulation than the younger patients. So essentially, you should carefully consider their comorbidities, because they are polypharmacy. So you have patients with elderly age who have a lot of medications, a lot of drug-to-drug interactions. Just consider those in mind. And again, in this one, you can see that both for stroke or systemic embolism and for major bleeding, there is a trend towards DOACs. So if you are going to start anticoagulation on elderly patients who are above 75 years of age, don't stop it or don't consider warfarin for that just for the sake of that because they are high risk of bleed. If they're high risk of bleed, they're high risk of bleed with warfarin as well. But DOACs are preferred over them in elderly population as well. Okay, so how about hepatic impairment? So again, I like this table. It clearly tells you if you are Child-Pugh A, no dose reduction is required. There are some who use with caution with Child-Pugh B, especially dabigatran, apixaban, and edoxaban. And then once you get to Child-Pugh C, actually they are mostly kind of contraindicated for these patients with Child-Pugh C hepatic impairment. Again, obesity is a big question mark that whether we use patients with who have BMI above 40, whether we should use the patients with with weight above 140, and especially the patients who have weight less than 50 kg. This is, again, telling you that the use of dabigatran, edoxaban, and betrixaban in some cases be avoided, and Riva and apixaban can be used with the caution. The data is low, but it's telling you that, yes, both of them, rivaroxaban and apixaban, have the highest data to be used in these population. This is just to show you, this is quite recent from Wang in 2020. So we know that obesity is an established risk factor. We know that the BMI high, patients with high BMI appear to have a lower stroke risk, but when you go to the above 40 kg per meter square of BMI or less, okay, these are the trials, different trials then, and again, you can see the DOACs are better performing in terms of the warfarin, both for stroke and systemic embolism, and in terms of major bleeding as well. They have divided into different categories of BMI as well. So for that, similar to what we saw in the renal impairment, so if you have a patient with a normal body weight, you can have any of the DOACs. If you have a severe obesity or BMI more than 40, you can use with caution rivaroxaban or apixaban, but avoid the others. If you have weight less than 60 kg, again, you have an option of apixaban and edoxaban are the ones who can be used, and you avoid others. So you see what the trend is coming up is that there's no one size fits all again. You have to very carefully select one of your DOACs according to your patient preference and according to your patient weight, renal impairment, and lots of other factors. Another one quite recent article in 2021, the ISTH, the International Society, recommends those who you are going to use DOACs over these population, they are recommending monthly anti-10A level monitoring, and also recommending to refer these patients to hematologists for some sort of DOAC drug level monitoring. Another article, showing 36,000 patients where they divided them into groups from 1 to 5 depending on their BMI, with the group 1, as you can see, BMI of less than 18.5, and good numbers. You can see that in group 3 you get 13,376 patients. These are the patients with the BMI of more than 30. So overall what it's, and also 10% are having BMI of more than 40. So what it's saying is that non-valvular atrial fibrillation, DOACs compared to warfarin were associated with better safety and effectiveness across all BMI categories. Sorry, can I just have a couple of more slides left?
Yeah, they'll give you 2 minutes.
So across all BMI categories, including underweight and morbidly obese patients. Very similar article again, in this time 71,000 patients, and the bottom line is that compared with warfarins, DOACs have more favorable efficacy and safety profiles among the patients with atrial fibrillation in different, whether you are using the standard dose or you are using the low dose. And that's my last slide to just show you it's difficult. You cannot just remember who is best for what. It is, there are some gray areas as well. You do need an expert recommendations as well, and that's just an overall graph somehow to show you that different DOACs are better in different domains. Some are better than others, but they are never being compared one-to-one trials. Thank you. I'm happy for questions.